The orange one too.
Okay. After the summer, the
Tina Wilson.
well. And then we have the rest. Thanks for joining us, everybody. We will get going here, and thank you very much, Alison, for offering to do this. I think it's amazing, and yeah, enjoy. I'll get out of your work and enjoy your food, breakfast, and yes. Hi, everyone.
All our online people as well. Yeah.
Yes. Hello to those of you online and in the room. I think it's very groovy technology when I've got a camera at this end and I've got a camera showing me how I didn't brush my hair this morning at the back end. My name is Dr Allison Hempenstall. I'm a public health physician for the Kimberley Population Health Unit just for a few months. I come from far north Queensland and am a public health physician for the Torres and Cape, and I used to be a GP living and working on Thursday Island for a number of years before stepping into this role. Very similar health issues that occur in far north Queensland and here in the Kimberley. But I'd love to hear what your health backgrounds are before we get going. I'll start with you guys in the room.
My name is Mosi. I'm a podiatry student at UWA.
Amazing. Welcome.
Bruce, dentist here. Private dentist in Brook.
Fantastic, Bruce. Thank you.
Tara, registered nurse, just did my bachelor, so I'm doing my graduate this year. So
Congratulations.
A physiotherapist.
Fantastic.
I'm Jessie. I'm one of the med students up here.
Lovely.
And I'm Tiara and I'm also a medical student.
Amazing. And you just come into the room. What's your health profession? Amazing. Yeah. Ah, what a lovely mix today online. Did anyone at Irene? What's your health background?
Yeah, I'm manager of infection control with a nursing background, but I've been in infection control for a long time. Yeah.
Fantastic, Irene. Thank you. Sue?
I'm a physiotherapist up in Kununurra in residential and community aged care.
Welcome, Sue. I should have guessed it with all those fitness balls around. Catherine, I think that's a Catherine, isn't it?
Yes. There is a Catherine. Is it me? Yeah.
Yes, that's you. I can't see your full name. Apologies. I had to deduce that's your name.
I'm Catherine Hollingworth. I'm a clinical nurse coordinator for Silver Chain in Broome.
Welcome. And the last person,
Gail Freeland.
Gail. Might not be there. Do you know Gail's health background?
Yes, Gail is, I'm pretty sure she's community nurse manager in Durban.
Wonderful. Yeah.
Yeah,
awesome. Thank you so much. So today, over the next, 40 minutes, we'll talk a little bit about diphtheria, the outbreak that's been happening here in the Kimberley, also West Australia, and it's trickled over into the Northern Territory as well. Really, this is not focused on teaching you about diphtheria because probably you're sick to death of hearing about it by this point. But really what we've learned from this outbreak, that's kind of the key focus of today's presentation. I use something called Menti. I don't know if any of you have used it before. If you want to grab your mobile phones and pull them out and go to, at the very top of the screen there's the little website, menti.com, and there's a unique code. And it'll prompt you to put the unique code in. We've got some questions throughout today's sessions, and so it'll be great for you to be able to interact with the session and for you guys online as well. So there's code there, 62862445, and it might be on some of the other slides throughout the presentation in case there's someone else who trickles in later on. I always feel like I'm on one of those late night shopping channels when I say they call for this number. But let me know if there's any issues, but hopefully that should be pretty straightforward for you. Great, we've got 5 people that have joined. And I wonder, Sarah, if it's possible with your computer just to turn the sound down a little bit. Yeah, thank you. 7, great. And while people are logging in, I'd like to acknowledge the Aboriginal and Torres Strait Islander people as the original inhabitants of the land on which we live and work. Paying my respects to elders past, present, and anyone with us today. How are you going there, Bruce? You're in.
Yeah.
You're in. Almost. Yeah, no worries at all. For these slides, I'm just entering a foray into using AI, and so AI have helped me create these images, which is really nifty, right? But also there's often some errors. But look out throughout the slide and see if you can see any errors. Here on the slide here, in the top left-hand corner, it looks like it's a coronavirus. And we're talking about diphtheria. I didn't change it, but you can see there's just small little quick quirks like that. Like I think this says 1.5 meters, and we don't really need to worry about that because diphtheria is droplet spread, so really need to be sneezed upon. But of course, you're going to be protected if you're 1.5 meters away, but you probably don't need to be that far away. How are you going? You're well, did it?
Yeah.
Amazing. Great. Okay, so a bit of a summary of an audit that we did with the first 135 cases of diphtheria. We had our first case in December last year. That was a severe respiratory case, a woman who was quite unwell from Kununurra, came down through Broome because she was so poorly she didn't make it to Perth on time. They stopped and stabilised her in Broome, and then she went down to Perth ICU where she was quite unwell, received some diphtheria antitoxin. She's made a full recovery now with no kind of long-term consequences, which is really great. From that time, we then had some cases in February, March, and it's kicked off since then. So this summary and these lessons was really from the audit that we did from that first case up until the end of June, knowing that we've still got cases, the outbreak isn't over. It's certainly dwindling down. We're seeing that in the NT and in WA, but that's where these stats are from. Just over half are female, almost all of them are in Aboriginal people. The kind of peak age group is around those who are, 20 to 34. Interestingly, almost 3/4 of them have had 5 or more vaccines. We say 3 vaccines is your primary course, and then they will have had 2 boosters, one when they were younger and one in adolescence. And so you kind of think, well, what's going on there? We're getting we're getting vaccinated. Why have we got this outbreak? And we can talk a bit more about that later. And then under a fifth have been hospitalised and been no deaths. So there's just a bit of a kind of overview of the cases so far. So first little question for you to try on your mobile phones. How effective do you think the vaccine is if we've had this outbreak? Because I'm going to be leaving up a little bit of yeah. Some people have certainly said, well, initially when the outbreak came out, maybe no one was vaccinated and all we need to do is vaccinate people. Some people thought, well, maybe they did get vaccinated, but they were probably at the cold chain, getting the vaccines to keep cold from Perth, a distribution centre, all the way across to remote Kimberley. Great. Most of you are actually saying it's pretty effective and excellent. Does anyone want to elaborate on what they think's going on there? It's okay if you don't know.
It's been no deaths.
Been no deaths? Yes. Yes, absolutely.
More or less to prevent the severity of infection.
Spot on. Yeah, spot on. So the diphtheria vaccine is a toxoid vaccine. It's a little bit like the COVID vaccine in the fact that it doesn't prevent you getting the disease. It just prevents you getting severe disease. Same with the flu vaccine. They get it every year, and then people 2 weeks later say, "Oh, I got the flu." Well, it probably would have got the flu in a more severe fashion if they hadn't been vaccinated. So this vaccination works. It is highly effective, and it is probably because we've got good vaccination rates that this outbreak has been mostly mild. So 2/3 of all the cases are cutaneous, and no one has died from a cutaneous disease, which is kind of a sore on the arms and the legs most commonly. 1/3 of those have been what we call mild respiratory, which can be quite difficult to diagnose because it's just like anyone who comes in with a strep throat or who might have, a virus and a bit of a sore throat. they're not very, very unwell. They're just a little bit unwell. And then we've only had that one case in the whole outbreak so far. You're in the Kimberley. That's been a very severe case. And interestingly, she hadn't had a vaccine for over 20 years. She received the 5 in childhood up to the age of 4, and she was 25. And so then she didn't have any of her adolescent vaccines or vaccines in pregnancy. And that's probably contributed to it. So, you can see the vaccination rates here are really great under 10. They drop off for teenagers, and then they drop off even more for over 20. And that's the vaccination rates as of now. And probably speaks to the fact that we have a really good national immunisation program for kids and adolescents. But then after that, there's no recommendations for anyone to get a diphtheria vaccine until they turn 50. They get a funded one. Now, a lot of people end up getting the vaccine before that because they fall over, scrape their leg, end up in ED, and they get ADT booster for the tetanus part of it, and the diphtheria is there. But it really shows, well, maybe we should be rethinking vaccinating a bit earlier in those kind of 20 years and over. But in saying that, there's certainly an argument to say, well, there's only been mild disease. So is that something that's really important? So do you know from it now, some of you will have been involved in some cases, other of you may not have been. What were really common symptoms in this outbreak that you might have heard or read about?
Mucous membranes in the throat and the wheeze.
Yes, that's right. The pseudomembranes, yep. Yep, mainly cutaneous, a sore throat, absolutely. Coughing, yeah, some people would be coughing, yeah. Respiratory symptoms. What's been really interesting, there we go, it takes a little while for it to go from your computer up to the sky and then back down, and feeling a bit unwell. Definitely for respiratory diphtheria, people are feeling a bit lousy, but not too unwell to require hospitalisation, as we saw on the slide before. What's really interesting is that this outbreak is very different to what we see in the textbooks. And the thing is, most medical students probably don't learn about diphtheria unless it's in the context of a vaccine, because we just haven't seen it here in Australia for so long. And when this outbreak first started, we're having to dig up all this old literature and black and white photos to try and show people what it looks like. And 100 years ago, this was the most, here in Australia, this was the most common cause of childhood death. And they would have wards just full of diphtheria patients. And these would be sick kids with big necks. And this was just before they introduced the vaccine in the 1930s. And so it's gone from being the most common cause of childhood death to seeing no deaths at all. So it is very different. And we're really rewriting the textbooks with this outbreak, because this outbreak has occurred in a well-vaccinated population. So you can see here what we've found in the first 135 cases that we've reviewed is that the symptoms are a little bit different from what we see in the textbooks. So here, cutaneous symptoms, they have redness, maybe some pus, and it mightn't be healing. But we talk about these kind of grey pseudomembranes, or pearly edges, ulcer-like lesions. We're not necessarily seeing that. A kid might have fallen off their bike last week, scratched their knee, come in because it looks a bit manky this week to the clinic, they've swabbed it and it's come back with diphtheria. So they do not look like the historical images that we have for cutaneous diphtheria. And same with respiratory. We're not seeing, apart from the one severe case that did have a pseudomembrane, this kind of grey, pus-like coating on the back of the throat that is kind of stuck to the back of the throat. We haven't seen any of that. They've just got enlarged tonsils, a bit of pus, that's not a membrane, a bit of difficulty swallowing, but Apart from that, they don't have the big bull necks that people talk about. They don't have the drooling and kind of really, really unwell features that we have previously seen. When we've looked at the swab results for those with diphtheria, the cutaneous diphtheria always comes along with some friends. It comes along with common skin bugs like staph and strep, which is then opens another question. What's causing the infection? Is it the toxigenic diphtheria? Or actually, is it the staph and the strep that, that we see often? And the nurses, remote area nurses out across the Kimberley say, how do we know who has diphtheria and who doesn't? Because these skin sores just look exactly like all the other ones we've seen before. That makes diagnosis really tricky. But interestingly, when people have swabbed the back of the throat, there aren't many friends. Most of them just have the diphtheria. You can see here, only a bit over 20% have other bugs with them, what we call polymicrobial, and most of those were strep. Again, you could say the same argument. Is it strep throat that they have? And we've just picked up the diphtheria. And is it just there as a friend tagging along for the ride, or is it causing the disease? It muddies the water and makes it really confusing. And so we found that to be an interesting component. And I don't have any good answers as to what to do moving forward with this particular dilemma, but we're talking with some very smart microbiologists down in Perth to see what they think about it. So if we think about people getting a test for diphtheria, you can imagine, like most tests that you would be involved in organising here in the Kimberley, take a while to get down to Perth and then get processed. What do you think is the average turnaround time for someone to have a swab, it be sent down to Perth, and then for them to get a positive result back? Because you can imagine an earlier positive result means that we can treat them and follow up with the contact and the contact tracing, which has been a big part of this outbreak. No one said 9 days, which is nice. You have positive thoughts towards those in Path West. Those who selected 7 days is right. It took on average 7-day turnaround time to get the result back. And Path West were working over the weekend. Their workload, at least tripled, which is just insane. But you can imagine that causes problems for people waiting a test result. It's kind of really reminiscent of those early COVID days when they had such high turnover and we were waiting for the PCRs to be done in the lab before the rat tests came out. And so I don't know if many of you will know that the very smart microbiologists and geneticists down in Path West created a new test for this outbreak. It's a direct PCR. So from the swab on the skin or the throat, they put it straight into a machine and look for the tox gene, the gene within the bacteria that releases a toxin and causes the disease. And that has been a game changer because it has meant that we have had faster turnaround times with our path results. And so that 7 days might have been even longer if it wasn't for this test. Still takes a long time because this test they can only do in Perth at the moment. Hopefully someone who is entrepreneurial could consider commercializing this and rolling it out to the gene expert machines that we have here across the Kimberley. So then, just like you've got the flu and the COVID that you can do at a clinic and just get it back in an hour, you might be able to do something like that. And it's the same technology that they can use. Otherwise, traditionally, the test is getting a swab, putting it on a plate, putting it in the incubator for 2 days at least, having someone read it under the microscope and looking for the diphtheria is really hard because of all the other friends that are there. The throat and the skin aren't sterile sites, and so there are other bugs that come there, and so it's really hard to find the diphtheria, and then from there doing a PCR. So this has been a real game changer, and it's a real credit to Path West for moving with the times and creating a new test like this, which is quite exciting. Yes, that's okay.
I'm sorry for this day. That's okay. Oh, good.
Lovely day. So do any of you know what we have been giving? The antibiotic, yes. I know the podiatrists will know for the skin, the infections that they see on their lower leg. What antibiotics do we give for, oh, hold on, but for skin infections, not for diphtheria, for skin infections? I had to read my question there for a second time. So do we give the bicillin, the injection? Do we give Bactrim, bicillin and Bactrim, or bicillin and azithromycin? I think I put an unusual combination of antibiotics there. What do we normally give for skin infections? Just in general. So normally we would give either bicillin or Bactrim for skin infections. Mainly we want to cover the strep because we're worried about acute rheumatic fever, rheumatic heart disease. Sometimes we give the Bactrim as well to cover for MRSA. Some clinicians like to give both together. So those of you who picked Bactrim and the bicillin and Bactrim are absolutely right. In this outbreak, people have been trying to cover for the diphtheria as well on skin lesions, and so they might have been given bicillin for the strep and the azithromycin. So there's no straightforward answer here. It comes down to clinical discretion, but we do use bicillin and Bactrim for skin infections for your strep and your staph, and azithromycin has been used first line for the diphtheria. What's interesting is 100 years ago, all those kiddies on the ward with diphtheria would have all got penicillin jabs, and that would have hit the diphtheria on the head. This strain or type of diphtheria is almost resistant to penicillin. So what we could have used, for example, for strep, we give bicillin for strep, that stops the acute rheumatic fever, might have helped with the diphtheria as well, and maybe historically did, but this type of diphtheria is where it's called intermediate penicillin resistance. So it's just not, if penicillin is not effective in clearing it. And so we can't rely on penicillin. That's why they've recommended the azithromycin. But you can imagine for all those working in remote areas, they've got to wait a week for the test results to come back at this point in time. What antibiotics are they going to give? You know, we're now going to give bicillin and for the strep, Bactrim for the MRSA, and different, you know, they're getting a whole concoction of antibiotics. So you can see that really, because of this resistance and because it's unlikely that we're just going to get rid of this outbreak completely, I think the people who write the guidelines around empiric treatment for skin infections are going to have to think again about what we give because penicillin alone won't fix it. Does anyone remember from any email that came out or anything that you read how long is recommended between diphtheria vaccines for adults in this outbreak? So before this outbreak, it was kind of every 10 years if you wanted to. That was only funded for those 50 years and older. But in this outbreak, so everyone here should be up to date with their diphtheria vaccine. How long was it before, since your last vaccine, did you have to wait? Looks like there's a bit of a divide in the audience. But those who selected 5 years is right. They are recommending at the moment, in the context of this outbreak, if you haven't had a diphtheria-containing vaccine in the last 5 years, that you should receive one, and that's free for everyone across the Kimberley. And so the previous guidelines of waiting until you're over 50 and getting a funded vaccine every 10 years thereafter really have to change, don't they? Because that's not working anymore. Even though it's a good vaccine and it's a mild disease, maybe we need to reconsider. This is quite interesting. So from those 135 cases, those who had cutaneous diphtheria, we looked at when they received their last vaccine. And the middle number, the median number of years was 2.5 years since their last vaccine. For those who had respiratory diphtheria, it's 6.5 years. And then that one severe respiratory case was 21 years. So you can see that the cutaneous disease is very common, and it has to be under 5 years since their last vaccine, but they're still going to get it, but they're not going to get really unwell. But those who get mild respiratory diphtheria, it's been a bit longer since their last vaccine, and you can imagine that the vaccine effectiveness wanes over time, which is why we have these boosters in the first place. So I think this is really interesting for those people that are writing the guidelines across WA. What do we do now? Do we look at changing how often we give a booster, so we don't wait until we're 50, to stop those who have the mild respiratory, but probably more important, the severe respiratory? Because if someone has had all their doses up until adolescence, they've had their 3 primary courses, they've had a booster in childhood, a booster in adolescence, they should be fine, right? But this girl, she didn't have her adolescence vaccine, and we can't assume all women are going to have children to need the booster for the pertussis component of it. There's going to be so many people out here who have followed the schedule, 21 years elapsed, and they could potentially get severe respiratory diphtheria if it is now circulating around the community and we can't get rid of it. So I think we're going to have to rethink when we give the vaccine, at how frequent intervals do we give additional boosters, and who that gets given to. And the lucky last lesson that we, is important to not forget is around housing conditions. And so even though we didn't go through all 135 cases and look at the quality of the housing that they're in, it is safe to say that many people across the remote Kimberley live in substandard quality of housing, where their toilet isn't working, fly screens are broken, they don't have a washing machine that works or running water. And these are incredibly complex problems, especially because a lot of the housing is government housing, and actually getting contractors to do the plumbing and the electrics to get to these very remote communities is challenging and costly. So I can see there's a big problem, but it would be remiss of us not to think about those primordial factors, or what we call the social determinants of health that contribute to this. Diphtheria is a disease of poverty, just like it is acute rheumatic fever, just like it is tuberculosis or leprosy that we see out in the Kimberley, and trachoma. All of these have got to do with substandard living conditions. Has anyone come across these 9 healthy living practices? These are kind of the underlying principles that environmental health officers use when going in and doing housing assessments, kind of the key components that they want to focus on to make sure our house is at standard. And the thing is, I really like this slide because they're things that we just take for granted, right? We just take for granted that the fly screen is going to be keeping out the flies. We take for granted that actually we're going to have a shower each day. But if you don't have a functioning shower, or it's spitting out dirty water, then that's going to cause a whole lot of other problems. So these are really nice, simple, healthy living practices that we should aim towards at a minimum for healthy housing across remote Indigenous communities. It's nice to summarise these here on a slide, but it's clearly a complex problem with politics and funding and resource allocation and remote locations and intergenerational trauma and the legacy of the stolen generation, all that contribute to the situation that many Indigenous people find themselves across the country. But it is important that we advocate higher up to the politicians to say housing is really important in looking at preventing diseases like diphtheria. So it's a bit of a summary of the kind of 7 lessons that we've gone through when we've looked at the first 135 cases of diphtheria. The vaccine is a good vaccine. It works because we've seen mild disease, but the symptoms are really different than we've seen historically. And we're at the moment, the Public Health Unit are collecting photos to use and share as a resource for clinicians with patient consent so that they can just see the range of especially skin presentations, some that look real gnarly and other ones that look really benign. We have to look more into the fact that they come with other friends. They come with the strep and the staph. And so how much of those are playing into the infection that they have? The diagnostic testing, super important and a real game changer, especially if we can roll that out across the gene experts in remote Kimberley. We can't rely on penicillin. And I think that the people creating the PERIT guidelines around skin are really going to have to reconsider whether or not we include azithromycin or not. And if we think about the vaccine, immunity wanes over time. And again, those people creating the policies around how often we give the vaccines is going to have to change as well. And then not to forget about the importance of housing in this. It's easy to get caught up in the bug and what we see under the microscope, but these bigger picture is really where you get your bang for your buck. So that brings me to the end of the presentation. This slide here, you can pop in a question if you want it to be anonymous. Otherwise, happy to have a chat. Yeah.
Anybody? Questions?
What do you thought, is there an underlying incidence of it that's been undetected forever?
Yeah, really, really great question. And the answer is yes, probably not forever, but yes. So in Queensland a couple of years ago, I was involved in a diphtheria outbreak. It was only 10 people, so this is really different, right? In a small Indigenous community called Wujul. And we went in and we vaccinated the whole population, but then we didn't see any more cases after that for a few years. Then a few years after that, out in the far islands in the Torres Strait, that border on Papua New Guinea, where there is free movement between Papua New Guinea and Australia, no passports, no border, you just get in a boat and you go across the little bit of water. And there's a lot of family ties. There was a kid there who was a Torres Strait Islander who had diphtheria, and all his family is from Papua New Guinea. And that strain is almost identical to the strain that we see here. And that was in 2023, and we're now in 2026. And so that strain then a few months later was picked up in a boarding school in Cairns, where in the boarding school there were some kids from the NT that came across. And the NT at the time weren't routinely testing for the tox gene. They'd see the diphtheria, they'd say, we don't care about this. This is normal skin flora, go on your merry way. And so slowly, I think this has been tracking from Papua New Guinea down to far north Queensland, across to the Northern Territory, across to here. And the tip of the iceberg was when we saw the severe case last year. And then all of a sudden, everyone was like, whoa, what's going on? Let's do some more testing. And all of a sudden, we found all these cases. So this is not what we see, and I haven't showed you an epi curve here today, but you see an epi curve. It's not the true distribution of the disease in the community. It's more an ascertainment bias, the number of people that we're testing. And now a couple of months later down the track, in the hospital, they're worried about PPE and do we have enough isolation rooms to put people in? Other people like, we don't want to do contact tracing when there's 20 people in the household. Everyone's getting a bit over it. Testing rates have gone down. So unsurprisingly, case numbers have gone down as well. That's not because it's gone away. It's because we're not testing. Good question.
I have a question.
Yeah.
Are you worried about the outbreak?
Can I say yes and no? So no, because just as this lovely man said, it is mostly mild. Yeah, I would be worried if we're filling up the wards in the hospital with sick kids or sick people who are dying, but we're not. But in saying that, just because it's not causing severe disease doesn't mean it's not important, right? How many people do you see with acute rheumatic fever who go to the hospital? Not many. How many people with rheumatic heart disease? Well, no, not until they get such severe heart failure that they need to have a valve replacement. But it is still important. And that really comes back to the fact, why do we have a government that is not investing enough in the housing? Bruce and I were just speaking earlier before, why do we not have a government that supports water fluoridation in parts of Australia? I don't actually know, is your water fluoridated here?
Yes.
There you go. That makes your job a lot easier. But these are the governmental issues that need to be advocated for. So if I'm not worried, then the government is not going to be worried. So I have to worry about that. Say this should not be happening. We should not be having trachoma and TB and diphtheria in these remote communities. Not because Indigenous people are dirty or don't get vaccinated or don't go to the health clinic, because their living standards are rubbish. So I have to be worried in that sense, but not from a death perspective. Good question.
Does the bug mutate and we're chasing our tails, or is it a slowly consistent thing?
So my understanding, and I'm not a microbiologist, is that instead of it mutating like viruses do, there are more like over time strains that sweep through the community, a little bit like strep A. And so whatever Corynebacterium diphtheria that we had that didn't have the tox gene before has now been overtaken by this one that does have the tox gene. And that churn happens slowly over time, over years, when people are touching each other and traveling and spreading. So not mutating per se, but similar to that. And so we do have this strain at the moment that has the tox gene, and they've gone and done special testing over in Malaysia to see, is the tox gene actually expressing itself? Because it's one thing to have a gene, right? But if it's not expressing the toxin, then we're not worried. But this one is expressing the toxin, which is why that woman got really unwell, and why the vaccine is protecting everyone else, because the vaccine is a toxoid vaccine. It protects against the toxin, and this strain, through this churn, does have the gene, and it is expressing the toxin.
We have a question.
Yes. Oh, this is nice. Thank you.
With the accuracy of vaccination documentation, how are persons called in that are due for a dose, or is up to the individual? Yeah, good question. So we have the Australian Immunisation Register, and it is mandatory for everyone to put the vaccines, any nurse, doctor, health worker that administers the vaccine, to put it on there. But that only came in a few years ago. Before that, there will be lots of people who have records on paper records, and we don't know it all. If we don't know, then it's a very safe vaccine. You could just give them a booster. Clinics, when people come in, can look someone up on the Australian Immunisation Register. And so that's kind of a bit of a, one way to approach vaccination. Wait for someone to present who is interested in getting the vaccine in either a pop-up clinic or coming to the clinic, or a vaccine drive, however it is, looking them up, seeing if they have the vaccine, and then giving them the vaccine. What would be nice if we could get lists for communities from the Australian Immunisation Register to say, oh, all these people have had it in the last 5 years, all these people haven't. Oh, let's go and do a knock on these people and see if they want the vaccine. But that, and that's something that we did in Queensland, but it seems a little more challenging here because of people moving between communities. Also because you've got ALSs and WAC services, and so the data is different in each of them. So getting lists, which would sound like a sensible thing to do, just logistically is way more challenging. Good question.
I was wondering, do you see an end to this outbreak, or just an end to testing?
Well, one results in the other, doesn't it? The end of testing is an end of an outbreak. I think it will have what we call a long tail. It will trickle off, and then we'll get a couple more. And someone has asked me, will there be a second peak Like we've seen all the peaks of COVID. And I think that there will only be a peak if someone in a community is really unwell. And if we get another severe case, then everyone in the community is going to be like, uh-oh, what's going on? I've got a symptom. I'm going to get tested. The clinic staff will be like, oh, no, I don't want to miss that severe case and be the one dealing with them at 2 o'clock in the morning. And the testing will come up and it will peak again. So I think that that's what will happen, and there will just be blips and blips until we have another churn or another sweep of a non-toxigenic diphtheria, which could happen. And it could be replaced by something else that doesn't have the toxin. Thank you. Yeah. Great questions, guys.
Okay.
If there's nothing more, that's it.
Oh my God, am I allowed to say this out loud? That you're the best presenter we've ever had. You know,
Everyone says that. You say that everyone. I won't be here next one, then you'll say the same thing.
No, I must admit, all our Morning Minds presenters have been absolutely exceptional.
Yeah.
But that was amazing. I'm not a doctor, I'm not a nurse, I'm not anything. And then I found that very interesting on the whole, you know, just I suppose with an interest in basic health and people throughout the Kimberley, the community, the whole Kimberley, just being up here. So thank you very much for offering your time. I just came out with a protest. We just straight up said willing to do this.
We
So
want to share this information. And when we do audits like this, we don't want them sitting. Oh,
I don't know what that is.
see you later. If that's somebody. Oh, no, you're just trying to ask a question?
No, yes.
Yeah.
But this has been recorded and will be available. And because I think the downside of this is a lot more of our physicians and doctors should have been here. And we tend to find that really hard to get the doctors and the GPs. So I'm going to do a big push of this video and just shove it all on their emails and tell them to watch it. Because I think it's really overwhelmingly important, some of the information that you need to share with everybody. So thank you so much. Very welcome. Thank you. Okay, well, there's still more food out there to stop this recording.
Yes.
How do I get out of here? That was great.
What year are you both in?
Second.
Second.
Oh, postgrad, yeah.
Yeah. Nice. Is this a clinical year for you?
No, unfortunately not.
Oh.
But we do hear about the theory quite a lot.
Yeah.
But
lectures. Oh, that's a bit